I've started recording.
Okay, well, thank you so much for the opportunity to share a little bit about what NextGen WellCheck and NextGen WellCare is doing in the Medicare annual wellness visit in the chronic care management platform for our physician clients, ACOs, and hospital systems. I promised a little history first. Medicare celebrated 50 years this last year. It started in 1965 as government insurance for individuals that were age 65 and over. It then allowed coverage for people under the age of 65 that had been on disability for 24 months. But this was insurance that only covered services for illness and injury after they happened. So let's fast forward a few decades. And because of medical advancements, because of technology, we're living longer, but we're not necessarily living better. Our seniors are suffering with a poor quality of life, and because these advances in Medicare spending has skyrocketed, they knew that something had to be done. So Medicare took their cue really from private and commercial insurance carriers and looked at preventative services, all about wellness. They knew that if an illness or an injury could be identified before it happens, it could be treated early, maybe even averted. And sometimes that spending could decrease and their quality of living increase if we could prevent it, or when we capture it, if we're able to help that individual manage that chronic condition a little bit better. So fast forward again, the Affordable Health Care Act, two things happened. Physician reimbursements were reduced. Unfortunately, again, Medicare is trying to control spending, but preventative services were added for that very same reason, to try to control spending.
Mhm.
In 2011, Medicare started offering the annual wellness visit. Based on their own numbers, about 16% of eligible seniors have received their first annual wellness visit. It's complex. It has numerous requirements. There's reporting criteria. Many physicians simply are electing not to do it, or when they do it, it's not a consistent effort. Also, with the chronic care management, that came about in 2015, a very new product that is being introduced nationwide to our Medicare population. Medicare themselves, at the end of last year, determined that about 35 million eligible beneficiaries could benefit from the chronic care management service. By their own numbers, less than 100,000 had enrolled. So the market is huge. When we're looking at the next 20 years, we're all baby boomers aging in, and we're turning 65 at a rate of 10,000 per day and will for the next 20 years. So our goal is to help Medicare patients live better as they live longer and to generate revenue for the physician clients that we serve. So that's where we're going to start. The first thing that we want to do, of course, is to be able to engage that existing patient population within that physician office. We're going to gather information. We're going to identify risk factors. We're going to make sure that results are there. We're going to help decrease the cost, better manage those patients that need some more help. And we like to start by saying there's no upfront charge of any kind. Furthermore, our physician clients do the billing, and then we get paid for our services after they get paid from Medicare. So let's start a little bit about what it involves. The first thing that we do is try to make sure that there's an education with that physician client. It's a different service. A lot of the physicians that you may run across, or even those that we're helping out here in the marketplace, think that initial preventative physical exam, that IPPE, is what an annual wellness visit is. The IPPE is the Welcome to Medicare one-time physical. It only covers a review of systems. The annual wellness visit does so much more than that. That review of system is the constitutional review. They do take vitals, but so much more. There's the functional capacity. There's a safety evaluation, a cognitive evaluation, a depression screening. We put in place general risk factors, a 5-year written plan, and we make sure that that patient goes home with personalized health advice, and it's done each and every year, and it's covered under that
Mm-hmm.
preventative services. And it's something that that Medicare patient, that beneficiary, does not have to pay for, and we compensate those physicians very well for that. What happens with the annual wellness visit? While you're looking at that information, one thing that we do is we want to make sure that we're engaging those individuals. We put together a business associate agreement first. That enables us to act as an extension of the practice. What happens from there, we're going to look at that practice and we're going to ask for assistance in gathering all their Medicare data on their patient population. So that office manager or that practice administrator or that physician themselves will allow us access into their EMR or EHR system, which is their electronic health records or electronic medical records, or into their billing system. We'll have our IT service and system talk with theirs, whoever is in charge of that, and extract that data. From there, we're going to double check phone numbers, addresses. We're also going to look at conditions that they have, but we're going to scrub that list, take that data, put it side by side against Medicare data, and see who's actually eligible for an annual wellness visit. Remember, about 15–16% of them have already had that annual wellness visit. We want to make sure that when we're communicating with those individuals that we're making sure we can talk about the right visit for them. So from there, now if they have 1,000 or more eligible, 500 or more eligible patients, we're able to do some marketing for them. What I mean by that, we're going to scrub that list. We're going to get the raw data of who's eligible for an annual wellness visit in that provider's office. We're going to mail them a postcard. Now, we take care of all of the postage and the mailing, and we know it's important to communicate with that individual in that way because it's a visual thing and it's right there and ready for them. The letter's going to tell them, or the postcard rather, is going to tell them that that annual wellness visit is now being offered by that practice, and we emphasize the word free, that there's no cost, that they're entitled to that visit. But we go one step further in our marketing. That patient's going to receive that letter in a time frame within a couple of days. We have a call center that's going to call that patient and say, hey, Miss Brown, it's Dana from Dr. White's office. You should have gotten a postcard in the mail the other day. Well, it's talking about the annual wellness visit, and I'm calling to schedule those visits in. Now, our call center is staffed a lot with senior citizens that have already had an annual wellness visit that can talk peer-to-peer. So there's that communication there on how important it is. And because we're doing such a concerted effort on the marketing side of things, we're getting much, much higher participation than that 15%. We are solely focused on the annual wellness visit. So we're making sure that that patient knows all of the advantages, all of the benefits, and we're scheduling them in about 30-minute time slots, either with a nurse or a medical assistant or someone in the office that we've trained to be able to do that visit. It doesn't necessarily have to be the physician. We're also going to call that patient a day prior and remind them of that visit. And of course, at that time, we're going to let them know again they're going to be seeing a member of the staff, not the physician, and to make sure that they bring a list of their current medications with them as well. So when they arrive at the practice, we're going to make sure that we have that review of history. We're going to list their current providers. We're going to take their vitals, risk factors. We're going to screen them for depression. And how do we do that? Well, we have proprietary software that's going to cover now. My information's a little old. It says 280 data points. That has been boosted up to 350 data points. We're going to gather information from that patient that's self-reported, of course, about diet and exercise and activities. We're going to gather information about smoking and alcohol. We're going to get their vitals. We're going to get a list of their medications. We're going to make sure they've had immunizations and allergies information. And at that point, we're also going to do a constitutional review of systems. We know if that patient's complaining of another problem, that we'll be able to open up that system, review those complaints so that physician has the most pertinent, up-to-date information. We take that very seriously because we know that if a patient's feeling dizzy outside of the office or even while they're there, that's something that needs to be brought to that physician's attention immediately. And then, of course, we're also going to put them through their PACEs with a functional capacity evaluation. Well, what does that involve? We actually have that patient sit and stand, stoop, squat, squeeze something with their hands for strength. We have them carry something, kneel, seeing if they can get back up. We're testing their muscle strength along with their bone and connective structure. We're looking for symmetry. It may even show a possible stroke situation. We're also going to evaluate the patient's safety. We're going to focus on handrails, driving, contact with family and friends. We also do a mild cognitive impairment. We kind of dive deep into that a little bit. The clock face has 9 components that we score. We also wrap up that 30-minute visit with a depression and anxiety analysis, and it's using the PHQ-9 scale. So all of this information, because of proprietary software, because it's automated, because we've already gathered information on the phone up front, because we've already looked at the algorithms on all of the data points that we collect, the visit goes very quickly, especially when that same person is performing that visit over and over again. What physicians' offices have told us in the past when they've attempted to do this on their own, that the visits have taken so much longer, but we have got it down into 30-minute slots for that physician's office. Also, what happens, once all of that information is populated into this software, it's going to produce some rapid results. And what I mean by those rapid results is going to show information that might be immediate for concern. As an example, this sample patient is showing that there's more than one chronic condition that they're dealing with. So they're going to be referred to chronic care management. There's also a concern for mild cognitive impairment. There was also a concern for depression. There's some diagnostic testing that needs to be done. So all of these are immediate triggers and information that's available for that physician and for that office, but also more importantly that patient's walking away knowing that something's being done to make sure that their health's going to improve or that they're going to prevent some of these things from happening because there were risk factors showing. Those are called clinical triggers. They're proprietary to our software, and those clinical triggers can also be personalized according to that practice, according to that hospital, according to that ACO. So when the visit is done, that nurse or that medical assistant is going to escort the patient to the front desk to be scheduled for a follow-up visit, usually 1 or 2 weeks down the road, so the physician has time to not only evaluate the rapid results, but they're also going to evaluate the information that we're going to compile into a provider report. So let me show you what the provider report looks like real quick. Let me pull it up here. And the the provider report, let's say that 3 times fast. The provider report has all of the components that Medicare requires to be compliant. In fact, this particular report was vetted and approved by Medicare in 2011. It has everything that they required and would survive an audit by CMS. Let me make sure this pulls up real quick, and let me make sure that you can see it on my screen well. It's loading, so thank you for your patience. Any questions about what we've covered so far?
Not so far. It seems pretty seamless so far.
Okay, well, good. Well, here's the provider report. Now, it reads like a soap note for the doctors so they can easily digest what's in the report. The sections that are covered here are often omitted but required by Medicare. Of course, we say here's the reason for the visit, self-reported problems, any allergy history, medication history, immunizations, family history, social history. These are things that the physician hasn't asked on that welcome to Medicare physical, or maybe doesn't have information from that regular physical that they're doing. Because if we also look at some of the other bits of information, we've also taken details about their diet on what they eat. We're also looking at their eyesight for macular degeneration levels. We're looking for exercise and activity levels, their functional capacity. You'll notice that we've put things in bold so they can look and go, okay, wait a minute, this particular patient, Miss Brown's at risk. You know, she's fallen in the last year. There's a concern there for her safety. Cognitive impairment. Again, Miss Brown failed on counting backwards from 100 by 5. There was also a fail on some of the other areas. So that physician's going to know right then and there that Miss Brown needs to come in for some further testing on her cognitive awareness. Also the mental state and potential for depression. Other observations that the patient may, have shared with them. Yeah, I haven't been to the doctor in a while, the last 2 months. I'm not taking my medications. These are things that we need to immediately alert the physician for. So here's that report. Here's that written documentation. And then this right here, the medical decision making, this is so important for the providers because what that does for them, it contains that information, right, that gives the practice proof and confidence that the treatments that are going to be recommended based on this annual wellness visit are justified. And if they're justified, they're billable. So it's additional revenue. Remember, we talked up front, 2011, the Affordable Health Care Act did two things, put in preventative service, but reduced physician reimbursement. This is going to give them justification for additional testing, additional services that they can now be compensated for, that they should have been compensated for. Risk factors. This particular area is also a requirement by Medicare. Medicare says if you're going to do an annual wellness visit, doctor, you must have risk factors listed, what the level of risk is, what any treatment options could be, and associated risks. And it's also required that there be a written 5-year plan on what's going to happen with that particular patient. As an example, in year 1, Ms. Brown's going to have an office visit. They're going to check her certain lab levels. She's going to have a standing, blood pressure goal. They're looking at also her BMI and where her range would be there, any immunizations that they want her to have, any standing lab orders. All of that has to be in writing in a 5-year plan. Finally, that information is also going to include personalized health advice that goes home with that patient. And it's easy to read so they understand. As an example, some of the risk factors, perhaps for this particular patient, was weight loss. So they try to make sure that it's easy to digest, so to speak. Try to reduce your sugar intake. We all know that fried food's tasty, but maybe at risk. So try substituting some things. So it gives them easy to read and good advice on there that's not being too pushy. So that provider report is what the doctor gets. Again, it was vetted and approved by Medicare in 2011. Now from there, going back to our presentation, all of that data, when it's all put together, when we're done with all of the annual wellness visits for those Medicare patients in that practice, all of that data has value. We've collected it on every patient every year, and we give that to the practice, to the ACO, to the hospital in a reportal tool. And it simply lets you or the practice download that data in Excel. You can print it out. You can use it on the screen. And there's different reports that are available. What's showing on our screen as an example is the risk matrix. Let's just say that this particular practice has completed all their annual wellness visits, and he's looking at his patient population as a whole. Okay, well, of my patients, risk factors, low, moderate, high, or severe, I have patients with diabetes in my practice. 23 of them are at low risk. 77 are at a severe risk. And all of these details or all of these numbers hyperlink into other parts of this process. As an example, the cognitive process here showing 31 patients at a severe risk. We can click on that link and it will take us to those 31 patients by name, with the top one at most risk right here, Mr. Joe Williams. He's at a severe risk for cognitive impairment. So that practice will know right then and there, based on all of the data, that Joe Williams, Mr. Joe Williams, needs to come in right away and get treated for some of these or have referred out to get some additional testing done. All of that data has real value for that physician's office. The risk stratifies that patient population so they can manage the patient population. They'll be able to click down even further and see additional information. Other reports are available to the practice in addition to the risk matrix, and they can use all of this data any way they see fit, whether it's trending data or whether it's other systems to review. Appropriate follow-up care is also part of the preventative services with Medicare. All of these areas are something that that patient is entitled to in that physician's office, and we try to make sure that there's resources available for those too. Finally, the annual wellness visit identifies and uncovers those patients that have chronic conditions. Chronic condition is defined by Medicare as something that's going to last 12 months or more and contribute to the functional decline of that patient. So when we look at that, we're saying, okay, the chronic care management, it's a new code. It's something brand new for the physicians as of 2015. Remember, Medicare said themselves there's 35 million eligible for the chronic care management platform service, but only 100,000 or less have taken advantage of it. So we want to make sure that we provide an education to the medical community on understanding that new code, how it's going to increase revenue, make sure that that patient interaction is good. And then there's also some other key objectives. We want to make sure that the patient's getting a better quality of care, another layer, so to speak. Make sure that they're satisfied with that and reduce the overall cost to Medicare. The facts are this. It started in January of last year, and to qualify, a patient has to have 2 chronic illnesses. We've already identified those or talked about them being 12 months or more as determined by the doctor. So when we say, well, what's a chronic condition? As determined by the doctor. It's something that's going to last 12 months or more. It could be arthritis and diabetes. There's 2. It could be COPD and cardiovascular concerns. There's 2. So any combination of 2. It's covered under Part B of Medicare. So that patient has to be fully informed because there is a copayment on some patients. Some patients have other Medicare coverage or services or insurance that covers that, but we need to make sure that they understand and they acknowledge that that's something that they want to participate in and that they understand how that works. Part of the requirements for the chronic care management, Medicare says there has to be 24/7 patient access to clinical staff, not the answering service after hours, but when the phone rings, a clinical staff member has to pick it up. The service itself is 20 minutes of tracked non-face-to-face time per month. Now what that means is those 20 minutes can cover a multitude of things. It might mean a simple medication reconciliation. There's 5 minutes. It might mean a patient-centered care plan being designed based on all of the data available. There's a few more minutes that are clocked that month. It might be referrals in and out to some specialists. There's some time done. It might be a phone call. It might be other ways of communicating with those patients. Hey, Mrs. Brown, did you take your blood pressure today? Those types of things. It's all tracked and documented time. CMS requires, of course, that all of that gets communicated not only to the patient, but that the caregivers for that patient have access as well, whether it's family members or friends that that patient would assign. They have to have a certified EMR. There has to be shared information back and forth. And again, Medicare says my objective is improving care, increasing satisfaction, and reducing the overall cost. And it's work. That's why out of 35 million eligible, only 100,000 have enrolled, because it takes time to identify the patients and onboard them, to do 20 minutes of documented care per patient per month and compile all those records, as well as produce a care plan and then distribute it out on a regular basis. All of that is work. So what we have done, we have proprietary software and a call center staff with clinical staff that does the work, and we'll talk a little bit more about that. But unique capabilities of this complete end-to-end solution for the Medicare patients is that it's comprehensive, it's compliant with Medicare. We produce all the required information plus the risk factors. We give them population management solutions, justifiable and billable clinical triggers, right, for the medical necessity of proper follow-up and problem-focused care. And we also generate in different languages on the documents that are required. That reportal system can drill down. We make sure that their EHR has the opportunity to import directly those documents. On the chronic care management side of things, the second service, these are two separate services, annual wellness and chronic care management. The chronic care management does a full integration. So what else happens is the full service system outreach to the patients. We screen them and we make sure that all that documentation is done. And of course, being utilized nationwide right now with a number of different providers, whether it's hospital and ACO clients or even associations that are endorsing this particular program and this particular platform of which we do business with. So let's talk a little bit about the benefits for the practice, the annual wellness and the chronic care management. The report format, it enhances the wellness, it's going to increase the revenue, and it gives better care for the management of those chronic patients or Medicare, even for just regular Medicare patients. The revenue opportunity can be huge. As an example, the GO438, which is the first annual wellness visit billing code, reimburses on average about $173 for that first year. Chronic care management billing code is every month and reimburses about $45 per patient per month. So we're going to talk a little bit about those. I'm going to pull up some details on the financial side of things for our physician clients, and we're going to review those quickly. Now, we're just assuming that $180 is our annual reimbursement rate for the GO438 on that first annual wellness visit. Remember, we know that 84% or better haven't received their annual wellness visit yet. For whatever reason, we know that 25% of the patients are not going to come through and do an annual wellness visit. Now, this is based on 5 years of data already, but we know that when we scrub that list and we get all of those that are eligible, that we mail them the postcard, we do the first phone call, we follow up with the other phone calls, still 25% are not going to come into the office and do the visit. But we also know, based on 5 years of data now, that we'll uncover and identify 2 risk factors that will provide some problem-focused follow-up visits for that physician. It's a 99214, 99213, 215 code, and they'll bill about $95. An average practice that we do business with has about 3 Medicare physicians on staff. Those 3 physicians probably take care of about 500 Medicare patients once all of that data has been scrubbed and we've verified who's eligible. So of those 1,500 patients, 25% not coming through, we know that in that calendar year we're probably going to do 1,125 Medicare annual wellness visits utilizing the next-gen WellCheck system. Just the reimbursement, net reimbursement for that physician client would be about $123,750. That's taking out our fees, that's them getting paid first. That is net profit to that practice for the time spent and the space done to do the annual wellness visit. But remember, we've uncovered 2 areas of concern that they're going to call that patient back in, and it's going to produce 4 office visits, 2 per condition. And at $95 a piece, it's generated another $427,000 in revenue for that physician. We add that to the original annual wellness visit net, and we've just put $551,000 back into that practice for taking care of 1,100 seniors, providing them with preventative services, helping improve their care and their quality of life, reaching out to them, and bringing them into an annual wellness visit. Let's look at the chronic care management side of things. Remember, 2/3 of them are going to qualify, and we're going to engage them in conversation to enroll in a chronic care management. Well, the chronic care management is the clinical staff that's going to be reaching out to them. We're going to make sure that that physician has the documentation and the tracking to be able to bill for this service in their practice. We act as an extension of that practice and to help them take care of that patient. It's $45 on average per patient per month reimbursement to that physician. Again, the same 3 doctors, 1,500 patients, remember 500 apiece. We know that 1,100 have done the annual wellness visit. About 2/3 are going to go through and enroll in the chronic care management. Our cost is $23 per patient per month, which leaves them net revenue of $22 per patient per month. So they're generating an additional $16,500 in revenue, or another $198,000 per year. We add that to the $551,000 here, and we've dropped in that physician's practice $250,000 for taking care of 1,100 Medicare patients for them, for standing alongside them and helping them care for those seniors and their patient population. We do it with all the documentation and all of the compliant requirements that Medicare requires, and we help that patient and we help that practice. That's what Next Gen WellCheck does and Next Gen WellCare does with the chronic care management. Any questions? Okay, well, thank you so much for being on the call today. If there are any follow-up questions, comments, I would welcome them at any time. You can reach me via email at dclark@nextgenmarketinggroup.com, or feel free to call me on my cell phone, which is 407-247-9091. Thank you so much for being on the call today.
Thanks, Dana.